Well, it's a real honor to be here, and I have really enjoyed the first two presentations. I'm going to talk today about addiction, and hopefully I can get out of here by 3:30. I'm sure you're probably getting a little bit sore here, so we'll get through this. So I have no disclosures. My background really quick as medical director of the Mississippi Physician Health Program. Our purpose is to provide a confidential mechanism to help physicians in their time of need. If they have any kind of psychiatric illness, addiction problem, provides a way to treat our brothers and sisters when they're in trouble confidentially to give them the same benefits we give to our patients. So all that being said, I'm going to breeze through epidemiology pretty quickly. In regards to primary care, 1 in 4 of the patients that come into a primary care practice are going to have an addictive disorder. 1 in 4 or 5 primary care visits will result in a prescription for a controlled substance. So does most folks here have a DEA certificate? Okay. So let's see, in 2012, there were 259 million prescriptions for opioids written in the United States. Decreased a little bit in 2013 and 14. Haven't seen 2015 data yet, but almost 260 million prescriptions. That's just for opioids. The population in the United States is about 320 or 30 million. So we're writing a lot of opiates. If you look at the total cost for addiction in the United States, most estimates now are above $600 billion a year. It's with a B. So approximately 30 million Americans have an addictive disorder. Somewhere around 2 or 3 or 4 million Americans are addicted to prescription opioids. So we've got a real problem. The CDC reported that now we're in the midst of the worst drug epidemic in the history of our country, and it's caused by prescription drugs. So we all know there's a lot of heat on physicians and prescribers, and we're getting blamed, and we do write the prescriptions, it's true, but there are many, many causes for it. And one of the causes is I think primarily a lack of understanding about addiction. In my background, medical school, residency in family medicine, and then a fellowship in addiction medicine, up until the time I started the fellowship in addiction medicine, I had never even seen a lecture on addiction as a brain disease. So, the total training I got related to actually how to treat addiction was probably maybe 2 hours tops. So we're all expert on managing the complications, cirrhosis, psychotic episodes, HIV, whatever. But as far as actually dealing with the underlying cause, we really need help. So these integrated care models and how we approach conditions like ADHD are really going to play an important part. So a key principle is that addiction is primary. It's not a symptom. It is a primary disorder. And all functions of the brain essentially are affected. Memory, reward, motivation, dysfunction in the circuitry leads to characteristic behavior. And ultimately, the dysfunction in the brain is manifested as pathological pursuit of reward. So addiction is characterized by inability to abstain, impairment in behavioral control, drug cravings, diminished recognition of significant problems associated with behavior or interpersonal relationships, a dysfunctional emotional response. All these represent really significant impaired executive function. So addiction involves cycles of relapse, remission, just like other chronic illness. Unfortunately, without treatment, it can also be fatal. I think, you know, part of the reason that people do drugs is to feel good. It's a primary reason. Also, some folks do drugs to feel even better. There are many reasons that we use substances, and ultimately somebody with a genetic predisposition or the person who becomes addicted really has no control over the way their brain responds to the substance once it enters the system. So the power of choice is involved prior to the first use. So in the 80s, we started the war on drugs. Nancy Reagan started the Just Say No campaign, and these were this good advice. This issue of Time magazine was released in May of 1997, and we often refer to the 90s as the decade of the brain. So we started to understand the reward circuitry of the brain, and we started to gain insight into the nature of addiction as it relates to specific parts of the brain. So dopamine, the neurotransmitter, was identified as a primary agent in this process of addiction and in the activation of reward pathways. So prior, for most of the history of humanity, addiction, or at least in modern science, we looked at addiction as a thought problem, really an executive function problem. So primarily a problem in the cortex. But as we know, any Dexter fans, if you were, you probably were scared to admit it, but he referred quite frequently to his lizard brain going off, and we think of this primitive part of the brain as being associated with survival behaviors, and anything related to hunger, fear, fight or flight, reproduction. These are all kind of parts of this more primitive brain. So when an animal engages in behavior that's associated with survival, like eating, drinking fluids, there's an association with pleasure, and the reward pathway is involved. So this activation of the reward pathways in regards to these behaviors is good because it means survival is good. When I'm thirsty, I drink water, it's pleasurable. It ensures that I survive. So in 1954, Olds and Milner published this famous study about the effects of sticking an electrode into the nucleus accumbens in a rat brain. So we figured out that activation of certain parts of the brain resulted in a pleasurable experience. And interestingly enough, the rats would actually press a lever to self-stimulate this part of the brain. And they would even ignore thirst, hunger. Male rats would ignore female rats in estrus. So these are really, it was a pretty powerful example of what happened when these reward pathways were activated. In 1962, another study was published in Science, and it showed that direct administration of heroin to the same parts of the brain resulted in these same behaviors. A rat would self-stimulate, press a lever to get heroin released to the brain, and it was relatively easy to get rats addicted as well. Definitely physically dependent. This comic, before you write it off as completely misogynistic, it depicts a woman crawling through the desert, dying of thirst, I guess. The sign on the right says fresh water, quarter mile. The sign on the left says half price sale, 2.5 miles, 2.2. And she's heading towards a half-price sale. I used to really not understand this phenomenon of shopping until I went into a Bass Pro Shops for the first time. It was like, I understood euphoria. So if you think about how powerful these survival behaviors are, look what an animal will do if it's dying of thirst or if it's hungry. And society understands that humans and animals will do what's necessary to survive, and we're pretty forgiving of that. Think about movies or books like Les Miserables or Alive. Has anyone read the book or seen the movie? You know what it's about? Cannibalism. About survival, exactly. And it involves a Uruguayan rugby team crashed in the Andes Mountains, and in order to survive, they had to eat the dead bodies of their fallen comrades. You know, these folks knew some of these people, and they ate their bodies. Now, eating human flesh is a felony, and I think every country or an equivalent of a felony, but these guys were not prosecuted because as society, we understand when it comes to survival, you kind of get a pass. So dopamine is a key neurotransmitter. There are other transmitters involved also, but this is really the go signal of the brain, and it's the primary neurotransmitter associated with pleasure. So dopamine is a catecholamine neurotransmitter. It's the biosynthetic precursor to norepinephrine and epinephrine, involved with motivational stimuli, sexual arousal, reward, thought, learning new behavior. When it's given intravenously or orally, it cannot cross the blood-brain barrier. So it doesn't have a direct effect on the central nervous system, but it's produced in the substantia nigra and ventral tegmental areas. This just shows the dopamine pathways on the left. You really can't see on the right serotonin pathways, but many neurotransmitters are involved in this process. And drugs of abuse influence these various pathways. So the dopamine neurons on the left and the yellow are involved with the pleasure, motivation, motor function, saliency of stimuli. The serotonin pathways are involved with memory, learning, sleep, mood. This is another old slide from NIDA. And it shows on the left the reward pathways consisting of nucleus accumbens, ventral tegmental area, cortex. The reward pathways, as I said earlier, are involved with natural rewards like food, hunger, appreciation of music, art. These are also involved. The middle slide shows dopamine release with food. A natural reward. The slide on the right shows dopamine release after cocaine ingestion. So you see supernormal concentrations of dopamine are released with drugs of abuse. This slide shows, it's a PET scan that shows the effect of cocaine on the brain. After ingestion, you start to see affected areas light up, the yellow areas, and over time, there's less activity here that actually is lower than levels before the drug use. So this is another slide that shows concentration of dopamine released over time. Now this, on the upper left corner, shows the release of dopamine associated with methamphetamine or amphetamine. And you see the rapidity, how fast the peak occurs and then how fast it decreases, and then the level as well. Highly addictive. Down on the bottom left shows the dopamine release with nicotine. And then the upper right is cocaine, morphine. So the amount of drug that's released, the effect of on dopamine release, I'll play a part. This is this article is published in Nature, and it explains the concept of a brief dopamine pulse. And so what they did was they created an audiovisual stimulus. It was a continuous tone with a light prior to the release of cocaine. So they gave it for 20 seconds, and what happened was this stimulus created a learned cue, and the rats associated this with impending cocaine administration. So this is similar to a cocaine user who sees a picture of drug paraphernalia. So we see a little dopamine surge there, just associated with the visual cue, not even associated with the use of the substance. A primary driver of repeated drug use is this horrific anhedonia and dysphoria, especially with opioid dependence. Anhedonia is difficulty or inability to experience pleasure, and dysphoria is just a horrible kind of a mood combining anxiety and fear and trepidation. And as addiction progresses, these become more and more powerful drivers of addiction. The ability to actually experience euphoria diminishes over time, and these two factors become more prominent. So eventually someone with addiction uses to escape these things. The idea of actually getting high is something in the past. So this slide is another older slide from Nora Volkoff, and it just shows the concentration of dopamine receptors in the brain. So in a normal person, the highest concentrations are in red. Somebody with morbid obesity, alcohol dependence, cocaine dependence, they have decreased concentrations of dopamine receptors. This is with active addiction. So, what is the role of the experience of pleasure, vulnerability? These are all related. Nora Volkoff is director of NIDA, wrote an excellent article about addiction as a brain disease published earlier this year. These are all online here, so if you ever want to look that up. But neuroplasticity refers to the capacity of the brain to reorganize, to create new pathways. So neuroplasticity occurs with addiction. When a person transitions from experimental drug use into full-blown addiction, new pathways are created. And similarly, in recovery, new pathways occur also. So ultimately, the behavior changes are all represent compromised neurocircuitry, and this occurs during the process of substance use. We don't know when exactly someone crosses that line and becomes addicted. What we do know is once that happens, it makes it really, really difficult. I'm guessing everybody in here has suffered from watching a loved one or a family member with addiction. Some of us here actually have experienced addiction ourselves. It is a horrific thing to see, and I guarantee you, well, I would bet money that no one in here has ever had an easy time getting a patient off high-dose opiate therapy, or high-dose opiate therapy combined with benzodiazepines. It's really tough, even if they haven't crossed the line into addiction. But once someone does become addicted, it's a totally different animal. Various parts of the brain are involved, and neuroplasticity occurs in all of these areas of the brain. So amygdala, associated with emotions, stress, desire; dorsal striatum, encoding of habits, routines; hippocampus, associated with long-term memory; nucleus accumbens, reward; prefrontal cortex, self-regulation; salience, attribution, which is the assignment of relative value to whatever it is. All these areas of the brain become affected. So Nora Volkoff described three basic stages of addiction: binge and intoxication, followed by withdrawal and negative affect, followed by preoccupation, cravings, which result in continued use. So, as we've seen earlier, addiction and addictive drugs cause circumvention of this normal process of satiation. We talked a little bit about the anhedonia, dysphoria, and the parts of the brain that are involved with regulating negative mood, regulating the sensitivity to stress, to stress, and sensitivity to distress. These all become involved. And the result is preoccupation, anticipation, and really significant cognitive distortion. So ultimately, there's an impaired response inhibition, inability to effectively say no. So Nancy's war on drugs, just say no, it's a great thing, but it really is not useful for people who have addiction, because a consequence of addiction is inability to say no effectively. And this impaired response inhibition results in this imbalance, or it represents an imbalance between desire for the drug with the will to abstain. Even the ability to remember consequences that happened the day before from drug use seem to not enter the consciousness of someone with addiction. So we talk about this impaired thinking, cognitive distortion, primarily associated with prefrontal cortex, but there's a lot of interplay between other parts of the brain. In 1939, the book Alcoholics Anonymous was published, and they described what happens in the thinking of an alcoholic, the inability to stay away from that first drink, even after experiencing trauma and horrible consequences the day before. And it's the alcoholic at certain times has no effective mental defense against the first drink. How many people in here have been baffled by our patients or family or loved ones with addiction? You know, they cannot stop doing it no matter what. I think, you know, most of us know the correct answer is, oh, it's a brain disease. But deep down inside, I think, you know, there's this idea that people with addiction just need to get their act together and, you know, get some willpower and demonstrate it. The way that addiction presents is different than other chronic illnesses. Active addiction results in pain all the way around. Pain to society, to family, and certainly pain to the individual. Someone with addiction that experiences cravings, that's the ultimate torture. You know, we know what it's like to crave things that are necessary for survival. So if I'm dying of thirst, I'm going to be preoccupied with getting water. My mood will become dysphoric. I won't have any pleasure, any ability to experience pleasure until I get water. And this is going to continue until I either get water or die. And this is kind of where someone with addiction lives every single day. So this is another PET scan. It shows the effects on visual cues. So they created two videos. One video was a non-drug presentation about nature scenes, river, mountains. The second video showed cocaine and drug paraphernalia. And recall the amygdala is associated with memory, invoking emotional response. So in an individual with addiction, when a drug craving occurs, the amygdala is activated. So what this translates to is if a craving occurs in the middle of the night, if it's raining, snowing, it doesn't matter. This craving demands that drug use occur immediately. And at this point, using the drugs is considered in an addiction, for someone with addiction, to be a necessity for survival. And this helps to explain why somebody with addiction will continue to use drugs. It really becomes an issue of survival. So really, if you look at the entire reward system, it becomes hijacked, so to speak, and the brain changes. The volume of receptors changes, dopamine receptors. There are negative effects throughout the brain. So ultimately, behavior changes are evident. Thought processes are affected. So we already talked about Nancy. This experiment involves fMRI studies. So fMRI is associated with blood flow. This is Mark Potenza. Back in 2003, did studies with pathological gamblers at Yale Medical School. He made 3 videos. The first was a happy scenario, the second was a sad scenario, and the third video involved gambling activity. Like someone had a stressful day, they came into money unexpectedly, and then they're in a casino with all the bells and whistles. So what it showed was that when a pathological gambler viewed this video involving gambling cues, it resulted in decreased brain activity in the regions of the brain associated with impulse control. So there's decreased blood flow to the areas of the cortex implicated in having impulse control. So the kicker to this, the really fascinating part of this experiment, and the N number is really small, like 14, but it involved 14 people with a diagnosis of pathological gambling, was this decreased blood flow, decreased activity occurred before the subjective awareness of excitement. So they saw the visual cue, decreased blood flow to the parts of, to impulse control. This is before the person even knew they're excited. So what happened in the control group with no addiction? Nothing. They looked at the cues. So this is a dramatic difference in brain function and response between somebody without addiction and somebody with addiction. As far as risk factors for addiction, we talked a little bit earlier about genetics, family history. However, and we talked about obtaining these in the history, extremely important. One take-home message I hope you leave with today as a result of this is, we've got millions of Americans on controlled substances, and the answer is not to abruptly stop giving those. If you do, we are going to have a health crisis of the first order. It's going to take a lot of time to effectively deal with these folks. What we can do differently is not cause new problems. So if you're thinking about treating your patient with anxiety disorder for the first time, don't reach to a controlled substance first. Try other modalities. Remember that dopamine spike? People are going to prefer Xanax over an SSRI. The Xanax is much better than Celexa because you're going to immediately have a sense of disinhibition. And so go with the non-addictive things first. Same with chronic pain. The problem is, and you're trying to make a living in primary care, and you have to see X number of patients just to break even. Somebody with addiction or that's drug seeking, they can take up an hour or 2 hours. So having integrated care is really, really important. But I think establishing a boundary up front. I don't treat anxiety with Xanax. We're going to try some other things first. So social factors play a role. What is the what kind of access is there to the drugs? What's the attitude about it? The route of administration, extremely important. IV use, intranasal use, smoking, much faster onset than oral ingestion. The choice of the drugs we already saw. Some drugs are even more addictive than others. And a key one is the age at first exposure. We see all these kids that are using amphetamine for ADHD. It's going to be interesting to see what happens 20, 30 years from now. Co-occurring psychiatric disorders, extremely important. There's a phenomenon called adverse selection, and it refers to the fact that the people most likely to suffer negative effects of a controlled substance are the very people that are likely to end up on that therapy. So people with comorbid psychiatric illness, addiction, are the people most likely to end up on Xanax and Lortab. So this cage screen has been around for a long time. It is a validated instrument. 4 questions, really quick and dirty. High sensitivity. 1 affirmative answer should really tip you off to a potential problem. So the first, have you ever felt that you should cut down on your alcohol use? And a key thing when you're eliciting history, especially from somebody with addiction, would you say that a dishonest presentation would be normal or abnormal? Yeah. Would you say it's even possible for someone with addiction to accurately talk about their substance use? No. So what I'm telling you is expect dishonesty. It's not that they're being devious. It's about survival. So, and if you're presenting that in a way that stigmatizes it or judges them, then you're increasing the likelihood that they won't be able to be honest with you. So, have people annoyed you by asking about or criticizing your use? You ever felt guilty? Have you had an eye-opener? All of these things indicate a pathologic relationship to the substance. So, the DSM-5 came out in 2013, and it combined the DSM-4 criteria for addiction. So in DSM-4, you had dependence and abuse. DSM-5 combined these into a single disorder measured on a continuum of mild to severe. So each substance is addressed as a separate use disorder. Of importance, caffeine dependence is not included as a substance use disorder.
That's good.
Yeah. There are 11 criteria. The first 4 of the 11 relate to impaired control over substance use. So if one of these are present, you have a diagnostic criteria. And before you tag somebody as being an alcoholic or in a diagnosis, that's a really serious diagnosis. So it helps to have actual diagnostic criteria. So taking larger amounts over a longer time than intended. If someone says to his wife, or I'm just going to go to the bar and have 2 drinks, and I'll be right home in 15 minutes. If they show up 3 hours later, or they miss their son's ball game or an important event, or if they end up in a different city, or something like that, you have that first criteria. So a great deal of time spent obtaining, craving. The presence of cravings are almost diagnostic of substance, of a problem. These next 3 criteria have to do with social impairment. So this is a result of using the substance. Use causing impairment in major role responsibilities at work. Continue to use despite problems. Important social, occupational, or recreational activities given up or reduced. If you think about that 7th criteria, it really makes sense. As addiction progresses, it becomes more difficult to experience pleasure, to experience that euphoria from that dopamine hit. And over time, the person is just going to hope for a little relief from the dysphoria and anhedonia. So if you talk to folks who are addicted to opioids, after being addicted for a couple years, if they're honest, they'll say, I haven't been high in years. You know, I'm primarily using just to try to feel a little bit better. So there's no really pleasure. So as it becomes harder to get that dopamine hit, so to speak, more energy is going to be put into the drug use to try to get there. So things like going to church or having a family meal together or going to a museum to look at paintings, you might as well say, you know, you want to put your hand on a hot stove, or it interferes with drug use. So this is a little out of order, but 10 and 11 have to do with pharmacologic characteristics, tolerance, withdrawal, and the criteria 8 and 9 have to do with risky use of the substance. So, recurrent substance use in physically hazardous situations. If a person's had 3 DUIs, you can probably count that as a criteria. It's supposed to be a joke, but it's not really funny though. Okay, so tolerance and withdrawal as criteria. This is a caveat. These criteria are not considered to be met for those individuals taking opioids solely under appropriate medical supervision. And now, this has played a part in why we are where we are today. If you look at the last 20 years when we started being sold the bill of goods about, you know, write Schedule II opiates for back pain or headache. It's perfectly fine. It's safe and effective.
The fifth vital sign.
Fifth vital sign, yes. Oh my goodness. I didn't even mention that. But so what folks were saying was, oh, well, they're not addicted because they're taking it as it's medically directed. Well, the key thing is appropriate medical supervision. The CDC came out with guidelines for prescribing opioids for chronic pain earlier this year, and they're really solid. The bottom line is that opioids, benzodiazepines, controlled substances, these are wonderful, wonderful drugs when used appropriately. When used inappropriately, they can result in a lot of problems, and kind of the reason why we are here today. So there are some folks who need to be on these medications. It is what it is. Just be willing to look closer at it. And so aberrant behavior suggestive of addiction. If you have a patient who has ever boiled a fentanyl patch and used it intravenously, there's your sign. So using oral and transdermal medications for injection, I mean, that's almost buying drugs on the street, forging medicines, using alcohol with benzodiazepines and opiates. These are all suggestive of a problem. In Mississippi, we have a prescription drug monitoring program. In Tennessee, you have one too, I believe, right? And very, very good. I mean, if you're prescribing controlled substances and you don't use this service, I'm not going to say it's malpractice, but I will say it's getting very close to it. The amount of information you'll get will be amazing. The patients who you feel like, oh, I'm good at picking out addiction, you'll be amazed at what you find on there. So, okay, so if you're going to use controlled substances, don't minimize the effects of a relapse. I think medically it's one of the greatest errors we've made nationally. I think, you know, we just don't have a good understanding about addiction. We're not trained or educated about it. And I think we have a tendency to minimize, like if you have an alcoholic and you're thinking about writing Xanax to them, and if you say, well, only take these if you really need them, I can tell you that benzodiazepines should almost never be used in a recovering addicted person. what do they do to inhibition? They cause disinhibition. That's what they do to the brain. They cause disinhibition. So addiction's about impaired impulse control. So if you give something that's going to make their impulse control even worse, you're exacerbating the problem. So giving controlled substances, that's associated with the production of cravings, even if you're not giving them their drug of choice. So really be mindful of that. If you're going to prescribe opiates, use the smallest dose possible. If someone has a minor procedure, don't write 100 Lortab. Say, look, take your 1 or 2 every 6 hours around the clock for 2 days, and then stop. So write a quantity sufficient for that time. So this is my interpretation. If you're talking about somebody with untreated addiction, remember, lizard brain is in control. May not be that second, but that's where they're living. So expect denial, expect cognitive distortion. It doesn't mean you have to patronize them, but if you expect this, it will increase your success. Think survival mode. A patient in active addiction will present situations that make your practice of medicine high risk for boundary violations. If a person's in survival mode, they will be desperate. So if you think a patient might have an addiction problem, if your instincts or your antennae are kind of getting activated, make sure you have a chaperone. So be kind, be patient, don't enable. A couple more. Recovery means brain healing. If you have pathologic activation, if you have activation of the reward pathway, using drugs, anything that's going to give you a supernormal concentration of dopamine, it makes it more difficult for the brain to heal. So total abstinence is a really good thing. Abstinence itself does not equal recovery. My job is to advocate for doctors with addiction. I say to whatever party's involved, medical board, malpractice carrier, this physician is fit to practice medicine with reasonable skill and safety. They had a substance use disorder, they got treated. They're doing X, Y, Z to maintain sobriety, and these guys, they're rocking, they're doing well. A common response that I've gotten, a question I've gotten was, well, this doctor hadn't had a drink of alcohol in 3 weeks. Why are you thinking about sending him to treatment somewhere? And the reason is that cognitive distortion involving the relationship with a substance and denial, this does not spontaneously heal with abstinence. It takes significant effort. Group therapy, wonderful. 12-step participation like Alcoholics Anonymous is phenomenally successful because it stimulates cognitive reorganization. It looks honestly at the substance use, honestly at the effects of the behavior on others, harms done, and it facilitates brain healing that will not happen just with abstinence. And another thing is, the brain, it's going to take a lot more than a few days to heal. So treatment's a lifetime process, just like you don't treat diabetes with 1 shot of insulin. It's the same with hypertension or any other chronic illness. This last slide is another PET scan. This shows the concentration of dopamine transporters in methamphetamine abusers. So the slide on the left shows a normal control. So the red areas have the highest density of dopamine transporters. The slide in the middle shows a methamphetamine abuser 1 month after the last use. So you can see the concentration of these dopamine transmitters is markedly reduced. We used to think that methamphetamine use in particular would result in permanent irrevocable brain damage, but you can see that in the meth abuser, 24 months after detox, begins to recover these dopamine transporters, so the brain is able to heal even in these cases. So recovery is a great thing. I know practicing medicine now is becoming more and more challenging. You have regulations, you got this and that, and electronic medical records, and the last thing you want is a patient coming in that's drug seeking or it's going to take up a lot of time. So this is a really great continuing medical education, and hopefully you'll get some good information from it. And thank you very much. It's really an honor to be here. Appreciate you. Thanks.